Welcome to Psychiatric Services from Pages to Practice, where we highlight new researcher columns published this month in the journal. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with our podcast editor and my co-host, Josh Berezin. Hey, Josh.
Hey, Lisa.
So today we're going to talk about 3 articles from the journal that have been recently published online. We'll look at whether outpatient commitment reduces mortality. We'll explore echo in primary care, and we'll explain echo when we get there, and see how mental health courts affect rates of recidivism.
We've got a full plate today. Let's start with Stephen Siegel and colleagues' study from Australia on the utility of outpatient commitment, mortality risk, and protecting health, safety, and quality of life. All of those sound good.
Yeah.
And when we were picking articles to highlight on today's podcast, this one just rose to the top of both of our lists. So what was the thing that made it so important for you?
Well, you can hardly get more controversial than outpatient commitment. Outpatient commitment is a practice that many think is essential and life-saving, and others think is a violation of rights. But it is something that is a part of our mental health system. And second, of course, mortality. Mortality is something that unfortunately people with serious mental illnesses experience at a far higher rate, and we know that people with serious mental illnesses live something like 10 to 25 years shorter than those without.
Yeah, and so
big issues.
As far as an outcome measure, you can't argue with death.
Exactly. Unfortunately.
Unfortunately. So this is actually an update from a prior Psychiatric Services article from 2006, where they found a decreased risk of mortality among people who were on outpatient commitment. That's called CTO in Australia. Mm-hmm. So there have been some changes since the period of time that they looked at in the public mental health system in Australia. So this one is updating that prior data. Mm-hmm. They looked at a cohort of about 27,000 people who were hospitalized from 2000 to 2010. And about 11,000 of them were placed on CTO, and the rest weren't. So they essentially compared the death rates between these two groups and looked at a number of common adjusted mortality ratios.
Right. And so I have to jump in here.
Jump in. Set me straight.
A really important issue here is the fact that the individuals who were put on a CTO order or who were on assisted outpatient treatment, that's how we would characterize it here, clearly differed from people who did not. So one of the things I really want to emphasize, just in terms of the methods of this paper, is that they have a problem of selection, and I'm going to use their words. What they did in order to minimize the expected differences between the group of people on CTO and the group of people who didn't get CTO is as follows. They did preliminary matching on age, sex, and diagnosis. They did propensity score control in the study models and statistical adjustment for potential confounding variables in these models.
So basically, instead of randomizing to 2 groups, because that wouldn't be feasible, they did these statistical measures on the back end to try and make the groups more or less equal so you can be comparing apples to apples.
Exactly. And this is never a perfect process, but they did what they could to equalize the groups.
Uh-huh. And so they found that, similarly to their previous study, that being in the outpatient commitment was in fact associated with decreased mortality. I think that's kind of the headline from the article.
Exactly.
Right? And there's a lot of mortality statistics in here. The one that I found kind of the most simple to conceptualize, particularly if you're talking over a podcast, was that being in the CTO group was associated with living almost 4 years longer for men and by about 2.5 more years for women.
Yeah. And that's a pretty significant addition of life for both men and women.
And so are they able to sort of talk about what they think is the reason for that, or were they able to look at that?
Well, so they had a lot of data
Yeah.
on these 2 cohorts, and what they were able to assess was the extent to which people who were on CTO accessed medical care. And in fact, as a part of the CTO order, individuals were required basically to obtain medical care. And so they were able to statistically look at the receipt of medical care in the CTO group, and then could, run the statistics, and found that the receipt of medical care accounted for a substantial amount of the reduced mortality.
So that makes sense, right? You're giving people more medical care, then their rates of death are going to go down.
Right. And as a skeptical researcher, I have to say, well, we can't completely establish cause and effect here. It's not the kind of design where you can say it with great confidence that medical care caused the reduction in mortality, but there's a significant and robust association suggesting that these two phenomena may be linked. And so the CTO led to the receipt of more medical care, which may have led to a reduction in mortality.
Getting back to why this article is so interesting to us, I think it gives us some food for thought about the trade-off and sort of the main tension that you mentioned about mandating something like medical care and the rights of the individual in these instances.
Yeah. So we're left with some evidence suggesting that outpatient commitment may be important or a tool in reducing mortality.
Good to know. Next up, an integrated care column from Miriam Komaromi and colleagues on enhanced primary care treatment of behavioral disorders with ECHO case-based learning. So ECHO seems like the hot new thing these days.
And there's good reason for it, because it focuses on changing medical practice, which we know is so difficult to do. So what is ECHO? ECHO stands for Extension for Community Healthcare Outcomes. And it's a model that, kind of in their own words, provides an alternative approach to ongoing training for healthcare providers. So we all know ineffective ways to train healthcare providers because we've all been a part of that.
We do that almost every day.
Right. And it breaks my heart because I do a lot of this.
I'm not talking about your interventions.
Oh, thank
Yours
you.
I learned
Thank
a ton
you,
from
Josh.
each time.
Okay, exactly. But what ECHO does is it uses video conferencing to simultaneously connect multiple primary care teams with academic specialists, or tele-ECHO programs, and build the capacity of these teams via mentorship and most important, and I just want to say this over and over, case-based learning.
Well, I think that the intervention that they describe in the paper is actually a great example of the model. So you have this common condition, right? Co-occurring substance use disorders with mental illness. And ideally, you'd be able to have a specialist come in and refer people to specialists and have them treat your patients, but it's just not going to happen in most, if any, places in the country. So what they do is they convene a team of specialists, in this case at the University of New Mexico. This one was an addiction specialist, a psychiatrist, a social worker, and a community health workers. And then primary care physicians can call in for free.
Oh, my goodness. So this is very interesting. So this isn't just for a psychiatrist to call in or an addiction specialist. This is for primary care physicians who are treating patients who have behavioral health disorders, mental health, and substance use.
Yes, this is integrated care.
Right.
It's actually happening.
Three-way integrated care.
This is exciting.
Yeah.
we're getting.
Right.
So what happens is the specialists who are sitting in a room at the University of New Mexico give kind of like a brief presentation on a particular topic, and then the rest of the session is people talking about real cases that they have problems with and getting a case consultation from this team of experts.
Yeah, and so you have the combination of knowledge, kind of raw knowledge, with then the opportunity to apply that knowledge for the care of people that these primary care physicians who are calling in have responsibility. So it allows this sort of ability to apply knowledge that you can apply. That's how we remember things. So, and I think the what's really impressive here is that the investigators or the program surveyed the participants, and they found that unlike, I think, a lot of CME, in which participants say, "Oh, this was fine, this was interesting, but it didn't really change my practice." So what they found, 70 of the 81 individuals who were surveyed rated the value of the input they received as 5, the best possible on a scale of 1 to 5. 86%, 254 of 295 surveys indicated that respondents learned something new from cases presented by others, and 93% reported that the information they learned would be useful in caring for their own patients. And again, when I present these data, the denominator or the number of people who responded is different. And this, I want to emphasize, this isn't a research article, it's a column. So, the rigor of the science is not what we expect in a research article, but it's suggestive and important.
It's thought-provoking.
Exactly.
Right? That's the whole idea.
Yeah.
The columns. And, they also present some qualitative reflections from participants, so the people who would be calling in. And I thought they were pretty impressive. So one that stood out to me was somebody learned that in traumatic brain injury to keep pharmacological regimens on a simple schedule. So that seems like, that's going to make a big difference in that patient's life. Like they might be able to take their medications more regularly.
Yeah.
I think the thing that brings them together is that they're actually, it's not just like they learn something new, it's that they're taking a piece of information or an approach and they're immediately able to apply that to both a specific case but also to their general practice. And I just love this one quote that they present from one of the participants. It says, "We got the help we needed to move forward with the patient."
What's more important than that?
Nothing. Last up, Evan Marie Lauder and colleagues study on the effectiveness of mental health courts in reducing recidivism. A meta-analysis. That's
Have you just invented something
I
new?
didn't. That's for a different journal. We'll move on.
We've got enough to cover in psychiatric services.
That's absolutely right. Getting back to business.
So you were talking about mental health courts. What are mental health courts?
So mental health courts, they're a diversion program. Somebody with a mental illness is charged with a crime, and if they go in front of a mental health court, they can have their charges dropped if they agree to some sort of treatment. So the authors point to a few key features that define these mental health courts. You have to have a separate docket. You have to have the judge supervise the treatment. The person has to regularly come in front of the judge to see if they're meeting the terms of the treatment. And those terms have to be pretty clear from the outset.
Okay, so mental health courts are really a key strategy in addressing this awful problem that we have in this country of the fact that people with mental illness end up in jails and prisons.
Yes. So even more important to figure out if they work. And in this case, the question of working means, are people committing crimes after they're done with mental health court? And the previous literature had been a little bit mixed on whether or not this was happening. And so this study was a meta-analysis of that question. So
just to expand on what you said in terms of an outcome, I think the studies and the purpose of mental health courts is to reduce recidivism. But
right.
Recidivism is multidimensional.
Right.
Recidivism can refer to reduced arrests.
Mm-hmm.
It can refer to reduced charges. It can refer to reduced convictions. And it can also refer to reduced jail time. And that's one of the lessons from this meta-analysis, is that depending on which aspect of recidivism or which outcome you're focusing on, the results differ.
Mm-hmm. And just to step back for a second and talk a little bit about what they did in general. So they looked at 17 studies and a total of 16,000 participants. This is that's a big number of people that they're looking at.
Yeah, so some of those studies were quite large.
Uh-huh. Yeah. And so when they looked at the meta-analysis in general, they found an effect size of 0.2 for the effect of mental health courts on recidivism. But as you're mentioning...
Which is a small effect size.
But as you're mentioning, there are a couple of things that seem to be associated with finding a bigger effect size. And one of those was the...
study quality.
The study quality, but also the outcome, right? How you... Like, what are we talking about here? So is it decreasing jail time? Is it decreasing...
So they found that there was a statistically significant reduction in recidivism when we talk about charges and jail time, and not a reduction or no difference when we talk about arrest and conviction.
Mm-hmm. So you're finding a bigger effect size when you're talking about charges and jail time.
Exactly. And it's very interesting because the nature of the study really mattered. So as we already mentioned, studies of lower study quality were more likely to produce a significant effect.
And then one other thing one of these other differences that they found was that they found a bigger effect size when they measured recidivism for a completed intervention, that somebody had gone through the entire mental health court process rather than being measured somewhere in the middle.
Exactly. So what they call is after exit.
Right.
So if someone was able to participate fully in the mental health court process, in those studies, the individuals were more likely to accrue benefit.
Mm-hmm. And, just sort of to wrap things up, I also, having sat in on a couple of mental health court proceedings, it just seems like the judge matters so much, and that these must be highly variable between mental health courts in different jurisdictions or different states.
Mm-hmm. And, clearly in implementing these programs and then assessing their effectiveness, it's very difficult to impose a standardization, but that's one of the challenges of developing these programs and building them, bringing them to scale.
And something that the meta-analysis can actually inform about, because there's so many different outcomes that they're measuring.
Yeah, so I think this study tells us that mental health courts do some good, in spite of all the different overall with the different outcomes. It does have a small effect size, which is not trivial.
Mm-hmm.
Small is better than none. At the same time, it's very clear that more research is needed, to see if we can boost the effect and understand more clearly under what circumstances mental health courts are effective.
So more to be done.
Yep. So that wraps it up for today. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
And I'm Josh Berezin.
Thank you for listening. We will talk to you next time.